So the Making Sense of Technology session was amazing. I was so lucky and thrilled to be part of it. I think today, how we think about using technology in diabetes has really moved eons faster than it was a decade ago or even 5 years ago. What I talked about is using technology to rethink how clinical trials are done. The second thing that I talked about was changing how we deploy and design technology. So there's really a profound irony in thinking about hypoglycemia and how we measure outcomes in clinical trials. Hypoglycemia is critically important, but A1C actually tells us nothing about it. A1C is a moving 3-month average, but it doesn't necessarily tell you anything about what the quality of life is like for patients, meaning how much hypoglycemia we have and how much hyperglycemia we have. Hypoglycemia is really dangerous and really costly, and we have to start measuring it in a more robust way. This will tell us much more about what therapies are really working and which ones aren't working. Specifically, what we'd like to do is to see more 24/7 use of continuous glucose monitoring in trials, or using the Freestyle Libre. That's something that is approved in Europe. It's not in the United States yet. We expect it to be here later this year, and this will give us a much more robust way of looking at how much hypoglycemia is actually occurring in patients. In the US, we actually spent $5 billion on hypoglycemia last year. 90% of that was in patients with type 2, and so much of this is preventable. Let's get to the place where we can put that $5 billion somewhere else. When we think about trial design as patients, we'd love to see it be much more diverse. When we go to FDA advisory committee meetings, the question always comes up, what does the patient population look like? We want the patient population to look like how the United States looks and how the rest of the world looks. It would be amazing if we could think about how to find many more underserved minorities to be in trials. So maybe we should be going to churches, synagogues to tell more patients about being in clinical trials. We'd also love to go out into the community much more. It would be terrific if we could work with manufacturers to figure out how to get patients in trials who could most benefit from being in them. That could be things like gathering even more patients with a lot of severe hypoglycemia and see how they do. It might be thinking about patients who are very newly diagnosed. We know those groups of patients are hard to get into clinical trials, but we probably could be smarter about it if we use more patients to identify them. It's really important to enroll many more patients who have mental illness in clinical trials. Mental illness needs so much more attention, and we need to start with getting them into more clinical trials and working with them in ways that make sense. Those who have severe hypoglycemia, those who are mentally ill, they are very often left out of trials altogether. And that makes no sense. We need to get them into these clinical trials. They are often the ones who could benefit the most. Population tracking could really help us better understand who could benefit from different therapies and technologies. Population tracking could really help us as patients avoid many catastrophic events, like going to the hospital, going to the emergency room. If we could identify patients who are at the most risk through smart population tracking, that would be a tremendous benefit to patients. We know that we could get smarter about software that could figure out and track the patients who are at the highest risk, for example, of going to the hospital because of DKA or because of severe hypoglycemia. If we can identify those groups of patients and give them the right technologies and therapies to use, we'll be so much better off. Our technologies could be used to help patients feel better, physically and emotionally. And everyone might not care about patients feeling better emotionally. What does that have to do with A1C? It actually might have quite a lot to do with A1C. It might have a lot to do with adherence, and things like this can be measured much more easily today. So things like, even if my blood glucose comes up with numbers that are really not numbers that I want to see as a patient, if something popped up on day 7 saying, great job for testing 80% of the time after dinner the last 7 days, how great would that be? And even if my average is 250, even if my average is 250 mg per dl, even if my average is 20 plus millimoles, for me to see that as a patient and then to point out, you're great to test, and maybe you should think about taking a walk, after dinner every day. Or maybe you should think about seeing an educator for carb counting. Really actionable, short messages can be conveyed via technology. We'd love to see more of that. We'd love to see more inspirational and empowering messages go to patients, because there's so much stigma out there as far as diabetes goes. If we could actually own the fact that there's way too much stigma out there, that some of that is what is causing all this mental disease, we would be so much better ahead. Let's own that and do something about it. We're sometimes fighting public stigma related to diabetes. We must make patients feel more empowered and more included, and like they're not alone.